Good afternoon. I'm Teresa Kelly, the Executive Director for the Health Council of West Central Florida. Welcome to the 5th session in our webinar series, Eyes on Equity Through the Social Determinants of Health. In this session, we will explore the role of trauma and systemic racism and how that impacts health outcomes. Our ultimate goal of this series is to stimulate action that leads to systems transformation and ultimately greater health equity. I would like to thank Baycare Health Systems for their generous support of this initiative. And I also want to thank all of you for being here today. During today's sessions, all the participant microphones will be muted. You will have some time to address questions at the end of the session. And if you have questions for a presenter during the presentation, please use the Q&A function at the bottom of your screen, which will be monitored by Allison Rapp, our Special Projects Manager. If you wish to offer a general comment to the whole group, please use the chat function. And you can also target that to individuals within the group as well. After the session is over, you will be receiving a list of resources, copies of the presentations, and a link to a recording of this session. We have two presenters today who will provide two different perspectives on this issue. Natasha Pierre is an award-winning author, speaker, and certified professional career and intuitive life coach. With over 20 years of lived mental health experience, her relatable style allows her to connect with global audiences to share the importance of self-awareness, self-advocacy, community building, and effective legislation. Natasha was born and raised in St. Thomas, U.S. Virgin Islands. She was diagnosed with bipolar disorder type 2 and devotes much of her time to mental health education and advocacy. She is currently serving as the Executive Director of the National Alliance on Mental Illness, commonly known as NAMI, for the Hillsborough County affiliate, and frequently shares her lived experience in the community with law enforcement crisis intervention training and is a subject matter expert for local news outlets. Natasha has a Bachelor of Arts in Mass Communications from Kyaien University in Pittsburgh, a Social Security Administration Work Incentive Practitioner credential from Cornell University, and certificates in post-crisis leadership and diversity, equity, and inclusion from the University of South Florida. She is also a faculty member for the Institute of Leadership and Lifelong Learning and is the author of Provoking Thoughts, Volume 1, 101 Inspirational Quotes for Daily Life, and is currently working on her second book, which is focusing on grief. Dr. Kyaien Connor is a tenured associate professor of mental health law and policy at the University of South Florida. She is a licensed social worker and is currently chair of the University of South Florida's Faculty Senate Council on Racial Justice. Dr. Connor received her BS in psychology from the University of Pittsburgh, so two ties to Pittsburgh. She has a master's degree in social work, a master's in public health with a specialization in minority health and health disparities. Her PhD is in social work and her postdoctoral training in psychiatry from the University of Pittsburgh School of Medicine, Western Psychiatric Institute and Clinic. Dr. Connor's research investigates the factors that influence disparities in health and mental health services utilization and treatment outcomes for racial and ethnic minorities. She focused on the development and evaluation of culturally meaningful approaches to improving behavioral health for African Americans. Dr. Connor recently co-produced a series entitled This Is My Brave, Stories from the Black Community, which has used storytelling as a culturally sanctioned strategy to amplify the voices of Black and Brown Americans with mental illness, reducing stigma and encouraging African Americans living with mental illness and substance abuse to seek care. Dr. Connor has over 45 publications that speak to the impact of her work, and she has presented at over 50 scientific conferences in the United States and internationally. Dr. Connor is focused on the development of policy and legislation which supports health equity, and she recently wrote a bill signed by Governor DeSantis on June 17th, 2021 to restructure the Florida State Office of Minority Health and Health Equity. I want to thank you both for being here today, and I look forward to what I'm sure will be an interesting and thought-provoking conversation. Natasha, I will turn it over to you.
Thank you so much, Teresa. As you were reading, I was like, oh my gosh, she's talking about me. Thank you so much, Teresa and Allison, and for, of course, the Health Council of West Central Florida for the work that you do for Baycare Health System and their commitment to eradicating and reducing mental health stigma in this area. I appreciate it. I am delighted to be a part of this conversation because it is absolutely apropos for our world today. And I am even more grateful that I get to share this webinar with Dr. Connor, someone who I respect and admire, and I look forward to hearing her presentation as well. I am the executive director for the local affiliate of the National Alliance on Mental Illness, the Hillsborough County affiliate. We are the nation's largest grassroots mental health organization with over 600 affiliates in the nation, and I'm happy to say even in the Virgin Islands. So we are not a small group, we are a very active bunch. Our pillars are in 4 key areas. We recognize that when it comes to the stigma that surrounds mental illness, it's not going to go away on its own. It really requires intentional and deliberate effort. And so we focus our work in 4 areas: education. Our courses are free. They are for the person living with a diagnosis as well as their family members. Our support groups, also free, for people living with and needing to understand how to live with their new diagnosis or one that they've had for a while, as well as the family members and how to be effective caregivers and offering support without losing themselves. We are very active when it comes to advocacy, not only local, but also statewide and federally as well. And last, things like this, public awareness. We've got to keep talking about mental illness until it's not taboo. And we recognize that it is still very much a stigmatized topic in our society. We're very grateful that last year we introduced Sharing Your Story with Law Enforcement, and at NAMI Hillsborough is a part of the current Hillsborough County Sheriff's Office Crisis Intervention Training Program. I actually provide the peer perspective that allows new and existing deputies to understand what it's like for a person living with a diagnosis to be interacting with law enforcement during a crisis. And I'm very, very pleased and proud to say that every employee of the Hillsborough County Sheriff's Office has received that training, whether they are public facing or not. So kudos to Sheriff Chad Chronister. Last year, NAMI introduced and revised several programs just to meet the needs of what was happening in our nation. NAMI Sharing Hope is specifically a program for Black and people of color. NAMI Homefront, a program for our veterans and military. NAMI FaithNet. We recognize that for centuries, people have ran to their organizations of faith for solace. And so our FaithNet program helps people who are in faith communities understand and provide support to those affected by mental illness. And lastly, one that we're really proud of, the NAMI Frontline Wellness. This is in response to our frontline workers, our doctors, nurses, healthcare professionals, our law enforcement, EMS, and our fire department, because of all that they had to deal with during 2020. So I'm very proud to be the executive director, the first executive director for NAMI Hillsborough, and to be affiliated with an organization that has taken a firsthand, all hands on deck approach to eradicating stigma in our society. For this first part of the session, I want to go over a session goal. This is what I have determined that if I can just get this done, then this webinar would have been a success. We're going to go over a support agreement, give you a review of the last year, what I saw with NAMI, what I saw in the community over the last 18 months. We're going to talk about racism as trauma. And then we're going to close with, or I'll close with, why we should all care. And then I'll turn it over to Dr. Connor. Before we even begin, I invite you all to take a breath. Racism, structural racism, trauma, it's a heavy topic, okay? But here's what I invite you to do. And if you can agree with me, I think we're going to be okay. Decide to remain engaged. Don't self-select out of discussion because you are not a Black, Indigenous person of color. Don't self-select out because you're not the 1950s or 40s racism or racist. That's not you. Don't self-select out because you don't think you have a hand or any work to do in this. We actually need all of us. Lean into any discomfort that you're feeling and trust that you can handle any feelings that arise. And I'm sharing this with you because I didn't know I was Black until 1994. I lived my childhood years and really up until maybe about 8 or 9 years ago. This wasn't my issue. I wasn't born or raised in the United States. This is an American issue. Well, it's not. Dealing with health disparities and health inequities and advancing and making our communities stronger requires every person watching. It requires all hands on deck. This is a shared commitment. The challenges that we're facing didn't occur in a silo, and in order for us to fix it, it's going to require all of us. The unity in community begins here. So I encourage you to stay engaged, don't disengage, and let's go. The CDC has shared that there are several social determinants of health. And over the last year, I have seen every area impacted with the communities that we serve. When we look at healthcare access, of course, many people lost their health insurance because they lost their jobs. They were unable to afford the COBRA payments. If you were a small business, we had many people who just weren't able to maintain the premiums because they had to close their business. But one of the areas that I don't think people were expecting were how many people were unable to connect with their psychiatrists, with their mental health providers, because they either died from COVID, they were no longer accepting insurance and went to cash pay, and the premiums simply just were too expensive for them to afford. When we look at neighborhoods, much of the work that we wanted to do in the school systems last year, we were unable to do because the schools had bigger issues, like ensuring that students were sheltered, that they were in a safe place. There were so many people, despite moratoriums on eviction, despite eviction protections, despite all of those things, there were many people who lost their homes, had to move out of their apartments. And that's happened throughout 2020. That's a stress. Being homeless, not knowing where you're going to live isn't a mental illness, but it is a mental health challenge. When we look at social and community context, 2020 was like the recipe for the perfect storm. We began the year with the death of Kobe Bryant and his daughter. Then came the pandemic and, looking for toilet paper and hand sanitizer, social distancing, the physical distancing, the isolation. There were so many layers to the pandemic in addition to the shutdown. And then we went right into the protests happening around the country as a result of the murder of George Floyd. And before we could take a breath, then came a very turbulent election. It was especially hard for students. And I really wasn't expecting the toll that it would take on our college students and even some of our high school students until some of them began reaching out to me and sharing the challenges they were facing with being away from home, being in an apartment with a roommate that had COVID, and just the challenges of life away from their support system. Very proud that we were able to partner with the Black Student Union at USF, University of South Florida, for 2 events. One was Bonnets and Blues for the ladies, and then Do-Rags and Discontent. I was excited about this event, but I can tell you that it broke my heart to hear college students share not only the mental illnesses that they were living with, but how they balance that with school, with working, with COVID, with the election, with the protests, with being away from family. It evidenced that we really needed to do more to support this population. And so NAMI worked with USF and with mental health providers in Hillsborough County to offer group therapy as well as reduced therapy to many of those students. Education, of course, we all did a quick pivot. If you had children, you now became the teacher. There were not just the the quick homeschool pivot, but there was also a technology pivot. There are many households that did not have the technology, whether it was internet, Wi-Fi, or the computers in order to support their children. And of course, we know about the economic toll. Many people lost their jobs. And all of these factors were coming into our support group. All of these social determinants of health, we saw in our support groups, people stressed, not a mental illness, but definitely a mental health challenge. That's what we saw last year. We supported people who were retired, they were financially stable, but they miss being able to see their grandkids and their kids. They miss being able to meet up with their buddies. We supported many people who were grieving. We've lost over 600,000 people in the nation. Those people were connected to someone and they're grieving. Of course, our veterans. We worked with many veterans who, just because of the stillness, were experiencing some resurgence of post-traumatic stress, insomnia, and anxiety. And of course, we had people who already had physical conditions, were immune compromised, and now they're dealing with some of the mental health challenges that came with the pandemic. It was a really tough time. One story that really hurt was a mom who lived upstairs with her son who had a heart condition and had had several open heart surgeries. And the husband lived in the basement with the older son who still wanted to attend school. Really, really tough time. And so mental health providers across the country, we did what we needed to do. We pushed that message. Mental health is health. Safeguard your mental health. Reach out. NAMI made sure that all of our programs were on Zoom. Everything went virtual. And of course, telehealth was introduced. We pushed the message that you are not alone. Reach out for support. And I think everyone got it, especially when it came to communities that were at risk, communities that were lower income, communities where we understood that, yeah, they may have a tough time with accessing services. But when it came to our first pop quiz that we had this year on how well we grasped that mental health is health, we didn't do so hot. Introducing Naomi Osaka, #1 women's tennis player in the world, champion. But when she shared that she was having some anxiety with dealing with the press, with dealing with the interviews, a mental illness, mental health challenge, the response was, give me a break, okay? You're a professional, stop being arrogant, you're acting like a spoiled brat. All right, so we had a do-over. How did we do? Not so well. Introducing Simone Biles, arguably the best gymnast of all time. Amazing. She's got moves named after her. And when she shared that, you know what, I need to step back from my mental health. I'm having some challenges with spatial awareness. It's not like she's playing golf. She's flipping in the air. I think that's a big deal. She had the death of an aunt. And when she shared those things and stepped back, she too was called selfish. Oh, give me a break. Suck it up, Buttercup. You're a professional. This isn't your first Olympics. But okay, these are women. They are Black women. Was the backlash due to race? Was it due to gender? Or was it due to their privilege? Let's use a real world example. I'm the executive director of a nonprofit. I have had a pretty accomplished professional history, done a lot of different things. Yet, in under 2 years, I've experienced 10 people close to me who have died. This past April, I was in the ICU with pneumonia, unrelated to COVID. I was septic, I was experiencing organ failure, and I'm grieving. On top of that, for over 20 years, I've lived with a bipolar diagnosis, anxiety and panic disorder, and post-traumatic stress disorder. And you know what my concern was over the last 2 years? I can't take a break. I can't take a break. Why? Because not only when I came to America was I taught that I am Black. Previously, I identified as a Caribbean girl. I'm from the Virgin Islands. No, America taught me that I was Black. America also taught me that Black women, you don't get to take breaks. If you take a break, you will be replaced. So we're not talking today about the 1950s, 1930s racism. We're talking about the tethers, the tentacles, all the ways that racism reaches out into our communities and affects people who we don't think would normally be affected. I had someone said that, how can racism affect you? You're typically like, the recipe for privilege. You were raised by two parents, you lived in a home, you're educated, you had hobbies, you don't have any visible tattoos, and you speak so well. I've heard all of this, and still, I am not exempt from racism. I'm not exempt from having tough interactions with the law enforcement, even though I work with them. I'm not exempt from microaggressions. I'm not exempt from micro intimidations. These are all things that I deal with. And so when we're talking about trauma and racism, we have to understand that racism is trauma. Racism is ongoing. And because the racism is ongoing, the trauma is ongoing. So in Black, Indigenous, people of color communities, there is no post-traumatic stress disorder because the trauma is still happening. Racism is driving our health inequities. Understand that when someone feels like they won't be heard, it delays self-advocacy. It delays their desire to share the challenges that they're experiencing. It delays and becomes a barrier to them accessing treatment when it's most needed. Understand that racism is part of the reason why our health equities exist. It's not genetic. It's not that, Black people, enjoy being sick or not having health care. This is structural. And in order for us to dismantle that structure, again, means all hands on deck. When we look at our micro communities, it's important for us to understand that we didn't get here overnight. At the point where a person isn't accessing, the healthcare that they need, at the point where a person is unable to really advocate for themselves, understand that that began a long time ago. Our nature, where we and what we were born into, if your gender assigned at birth aligns with how you identify, that's great. But if it's not, that's a challenge for you. The skin that you were born into, all of those things affect and impact what experience you have growing up, what you're able to access in your community. And of course, those impact what you're able to acquire in society. Why should you care? Because that's the question. If you are not Black, if you're not Indigenous, if you're not a person of color, why should you care? If you're not really interacted with any BIPOC people, if you're not married to them, you didn't adopt them, if it's not, you don't feel like it's your issue, why should you care? One of my absolute favorite words is Ubuntu. Ubuntu means that we are inextricably linked, that there is nothing that can happen to me that doesn't affect you. Health inequities, health disparities, it's far-reaching. If it affects me, it affects you. And there's the spillover into other communities that we need to be aware of. And so if you feel like you aren't being impacted, trust me, you are. Health inequities, it's avoidable. This is something that was created and something that can be dismantled. And it's un-American. We can't say life, liberty, and the pursuit of happiness. We can't say equal rights and justice for all when it's really equal rights and justice for some. Why do I care? I care because, as Lizzo said, my very existence is advocacy. I intersect with so many areas when we talk about trauma and structural racism. I'm Black, so America taught me in 1994. I'm a first-generation American. My parents were born and raised in Trinidad and Tobago. My grandmother is Hispanic from Venezuela. My great-grandmother is Carib Indian Indigenous. I live with a disability, and I'm a woman. I have no choice but to care. So my work, my life, everything that I do is to dismantle all of the barriers that prevent people from being able to access, afford, and enjoy the healthcare that they need. I'm going to pause right there because I get to introduce and turn it over to someone that I'm really, really happy to do this webinar with, Dr. Kyaien Connor. We have been working peripherally for a while, but now I get to hear her. Dr. Kyaien, it is on you. Thank you.
Natasha, that was an amazing presentation. I found myself in awe and almost forgot that I had to speak because I was so excited by all the important things that you said, and just want to echo that the sentiment is shared. So excited that we get to do this together finally, and really, really happy for additional collaborations in the future. So thank you. All the things that you shared were so important, and I think a lot of what I'll touch on in my talk definitely aligns with a lot of the things that you said, but I think it's so amazing and empowering your willingness to share your personal story, because I do think that that has a huge impact on stigma of mental illness, particularly in the Black community, where we often don't have role models that we can look at and say, wow, look at her, look at all the amazing things that she's accomplished, look how beautiful that she is, and she's dealing with this, so I don't have to be ashamed about some of these mental health concerns that I'm dealing with myself. So thank you for being willing to share your story. I think it makes a huge impact, and you certainly are a role model for me and for others. So thank you all for being here. As a professor, as a clinician, as an advocate for mental health, but also for racial justice, these talks are very important to me. I'm going to provide a little bit more of an academic sort of perspective and give you all some interesting facts and statistics that I think are important because, and Dr. Phil is not necessarily my idol, but he says something that I like, which is you can't change what you don't acknowledge. And I think a lot of these issues around race, around mental health, around systemic racism, we're not making as much progress as we could have because a lot of us are unwilling to talk about the issue. We're unwilling to acknowledge the reality that we live in. And we can't change this if we're unwilling to have that conversation. So I'm going to talk about a few things, starting with just some background, I think, on mental health, because it's important for us to remember that mental health is more than just mental illness. I think that oftentimes in many communities, there seems to be this very black and white perspective about what that means, that you're either mentally healthy or you're mentally ill, not recognizing all the shades of gray in between and how many of us fluctuate through different phases of mental health and well-being over the course of our lives, maybe even fluctuate within the course of a given day. But mental health really includes our emotional, our psychological, as well as our social and spiritual well-being. It impacts how we think, how we feel, and how we act. It determines how we handle stress, how we can relate to others, how we make choices. And mental health is critically important at every phase of our life, from childhood through adolescence, adulthood, and older adulthood. And positive mental health allows us to realize our full potentials, to cope with the stressors of everyday life. And as Natasha pointed out, we've had a lot more of those stressors in the last couple of years, allows us to work productively and to make meaningful contributions to our communities. So again, this is not just a state of being, this is fluid, and it's something we can actively and intentionally address, but often something we don't have complete control over. And this is part of the thing that's been frustrating about some of the backlash from some of our athletes in the media, this idea that we should have control over our mental health, this idea that we should be able to get through these situations without needing help, without needing to take a break. And those, myths and those misunderstandings can just exacerbate symptomology and contribute to additional mental health challenges for those individuals, but also for all the people who are looking up to them as role models and seeing how they've been treated, which ultimately can make them feel concerned about coming out and speaking about their own situations. mental illnesses or mental health disorders that obviously cause psychological and behavioral disturbances, but they do so with varying severities based upon the type of illness or disorder. What we do know is that mental health conditions are often associated with greater morbidity than many physical health disorders. And what does that term morbidity mean? So we're talking about burden, we're talking about disability, we're talking about the impact on one's ability to function. And what many people don't recognize is that mental health disorders are actually the number one cause for disability in the world. They are the number one cause for days of lost work, the number one cause for a variety of other physical health conditions. So we're not often recognizing the significance that mental health problems are having and how they are affecting a vast majority of our population. Mental health disorders are incredibly common, yet continue to carry great stigma. And this is something that we really need to do something about. So just how common are mental health disorders? I want to try to get some engagement with the audience here. And we have our first poll question. How many adults in the United States will experience a mental health disorder in any given year? Now, I'm not sure because I can't see yep, here we go. So here are our options. Do you think it's 1 in 5? Is it 1 in 10? Or is it 1 in 20? How many adults in the United States in a given year will experience a mental health disorder? What do you think? Take a few minutes to provide a response here.
Dr. Connor, I see the responses coming in.
Awesome.
We're at 63% of everyone who is participating. So can wait another couple seconds to get those last few in. All right, we're at 67%. You ready to go for it? Oh, we got more there. As soon as I say it, there's more coming in. All right, I'm going to go ahead and end the poll now.
Awesome.
And share the results.
Okay. Well, so 70% of you have done your homework and already know a lot about this. So you're exactly right. It is 1 in 5. So in any given year, 1 in 5 American adults will live with a mental health disorder. Oops, I am having trouble going forward in my slides now after that poll. Let's see what I can do here. There we go. Okay, so 1 in 5 US adults will experience a mental illness in a given year. 1 in 20 US adults will experience a serious mental illness each year. So this might be something like schizophrenia or a severe psychotic disorder. 1 in 6 youth aged 6 to 17 will experience a mental health disorder in any given year. These numbers for our youth are increasing every year, and the age where we are beginning to see symptomology of mental illness and concerns in young people continues to get younger and younger. We know that 50% of all lifetime mental illness actually begins by the age of 14, 75% by the age of 24. So as Natasha correctly pointed out, this is an issue that's affecting our young people in greater numbers, probably greater than most people actually recognize. In fact, suicide is the second leading cause of death among people aged 10 to 34. And yes, I did say 10 to 34. We are seeing a spike in suicidal ideation and in death by suicide in young people. You've probably seen some of those headlines in the media, but this is an incredibly scary situation and helps us as mental health providers to recognize that we need to be doing more to be targeting education and awareness about mental health to even younger populations, because this is a growing concern. And part of this spike certainly has happened in the past couple of years. And many experts have aligned that with the pandemics that we are experiencing, the pandemic of COVID-19, the pandemic of systemic racism, and the isolation and the variety of other experiences that Natasha mentioned earlier that have plagued our young people and have certainly created a very different environment for them than many of us thought that they would be experiencing at this time in their life. So I have another poll question for you. What are the two most common mental health disorders? So we've identified that mental health disorders are common, that 1 in 5 US adults will experience a mental health condition in any given year. But what do you think are the ones that are experienced the most? And you can select multiple answers here. We're looking for 2 choices. Is it post-traumatic stress disorder, obsessive compulsive disorder, major depressive disorder, anxiety disorders, schizophrenia, or borderline personality disorder? I'm going to give you a minute here to select your responses.
And I do see those responses coming in. While we're waiting for the responses, I do see that there are some questions. And please do keep entering the questions in the Q&A, and feel free to use the chat for chat. But I want to let you know that we will have time for question and answer after the presentations. So definitely keep typing them in, but I just want to let you know that's when we intend to do that. All right, we're at 68%. I think we're good to end the poll and share.
Awesome. All right, so very, very close here. 100%, you guys got this right. Anxiety disorders are the most common mental health condition. And there's a pretty close tie here between post-traumatic stress disorder and major depressive disorder, but it actually is major depressive disorder that is the second most common mental health condition. So you guys did a really great job here. In the next slide, I'm gonna just give you a quick synopsis of some of those statistics so that you can have a better idea of what we tend to see in the United States. So anxiety disorders impacting about 20% of that population, an estimated 48 million people every single year. Major depressive disorder, about 8%. And then post-traumatic stress disorder is a close following third, about half that of major depressive disorder, but obviously still experienced by a vast majority of folks. So in a given year, we're talking about, almost 100 million people that are experiencing some sort of mental health condition, anxiety and major depressive disorders being the most common of those. Great job. One of the things that I think is important for us to remember when we're thinking about mental health conditions, especially when we're talking about these experiences that we're seeing in the media and sort of the backlash that some of our athletes and other role models have been receiving, is that there tends to be this myth that there's something that we are controlling, something that we should be able to do, that we should be able to pray away that, depression, that we should pull ourselves up by our bootstraps and be professionals and keep going, not recognizing that the primary cause of mental illness is biological factors. These are things that we don't have control over. Brain chemistry, hormonal imbalances, other things as well, like poor nutrition, exposure to toxins, and often mental illness can be triggered by a physical health condition. There are other causes as well, family history. We know that genetics plays a huge role, and we know that mental health conditions tend to be hereditary, and that if you have a family member who's experienced a mental health condition, other family members are significantly more likely to experience one as well. But then there are also life experiences. Exposure to grief and loss is a huge trigger for a mental health condition. And as Natasha pointed out, many of us have been experiencing overwhelming amounts of grief and loss in the past couple of years, and not just from the death of loved ones, right? The loss of employment, the loss of mobility, the loss of our social support systems and networks. Those are all losses that may have a greater impact on some than others, and we have to recognize the impact of that, but also experiences of abuse, and then of course, the experience of trauma, which can take place in a variety of forms. So let's talk about race and mental health and begin to think a little bit about the trauma of race and how that may have an impact on mental health. It's important for us to first have a better understanding of some of the disparities here. According to the Office of Minority Health, Black adults in the United States are actually 20% more likely than white adults to report persistent symptoms of emotional distress, such as sadness, hopelessness, feeling like everything is an effort. So while prevalence rates for most mental health conditions are largely similar, meaning that the percentages of African Americans who are diagnosed with depression in a given year are pretty similar to that of non-Hispanic whites, Black adults are more likely to report severe and persistent illness that is resistant to treatment and are more likely to present significant symptoms of distress that are having an impact on one's ability to function. We also know that Blacks who are living below the poverty line are more than twice as likely to report serious psychological distress as poor whites. So African Americans are also involved in other populations that are at a greater risk for the development of mental health symptoms, right? So we're more likely to be impoverished, more likely to experience incarceration, more likely to experience homelessness, and all of these things place African Americans at a greater risk for poor mental health. So these are things for us to take into consideration. But we also know that we're seeing some similar kinds of disparities for Black youth. I mentioned sort of this issue that we're seeing now with a spike in mental health symptomology at younger and younger ages. We know that Black teenagers are more likely to attempt suicide than white teenagers. This is actually a much more recent phenomenon. We were not seeing this 10 years ago. And so there's a great concern right now about not just Black youth, but also Native American and Indigenous youth who are at a greater risk for suicidal thoughts, but also death by suicide. We also know that Black children are more likely to have a mental health diagnosis while simultaneously having less access to mental health care. They're more likely to have made an emergency department visit for a mental health concern, very likely due to delayed treatment seeking, such that they end up in the emergency room in crisis due to something that might have been able to be treated in an outpatient setting. And of course, significant relationships between childhood mental health issues and criminal justice, which creates a variety of additional complexities that we don't have time to talk about here, but happy to talk more about that in Q&A if people have questions about this. In addition to mental health disparities, we see a mass amount of physical health disparities, illnesses that are impacting Black communities in very disparate rates. Rather than using the poll, happy for people to put in the chat at this time, if you can think or name any sort of physical health condition that you recognize or believe that are impacting African Americans in a disparate way. Yep, I see some coming in: diabetes, hypertension, COVID, yes, heart disease, prostate cancer, fantastic. Metabolic syndrome, absolutely. Oh, Joshua, hi, Joshua. Yes, you name it, absolutely. Sickle cell, yes. Breast cancer, yes. Absolutely. Poor birth outcomes, exactly. The point here is that the list goes on and on. Someone says you name it. That's everything unless genetic. That's absolutely right. That's absolutely right. When we think about health disparities, right, we're talking about the experience of an illness or the incidence of disease or a response to treatment or an outcome that is not due to genetics, that is not due to biology, that is due to an unfair or unequal social circumstance that is creating outcomes or creating these numbers that are preventable, unnecessary, things that we could do something about. And that's what makes health disparities so frustrating, is that we recognize that these things don't have to be. We recognize that these disparities don't actually have to exist, that we could do something about them. And yet, despite years and years and decades of research studies and interventions and Healthy People 2000, Healthy People 2010, Healthy People 2020, and there will be a Healthy People 2030, which have all focused on addressing health disparities. Unfortunately, these disparities continue to exist and they're getting worse. They're not getting better. And this is an incredibly frustrating situation for those of us in healthcare settings. This is just a snapshot of what we see. And as all of you pointed out in your chat, there are a variety of more things I could have put on this list, but we know cardiovascular disease, African Americans 20% more likely to die, twice as likely to have diabetes, significantly more likely to die from diabetes, twice as likely to have hypertension, significantly more likely to suffer from disability and have complications from hypertension, cancer, a variety of cancers, and the highest death rate for almost all of those, significantly higher rates of obesity, infant mortality, as well as maternal mortality for African American mamas and their babies, life expectancy, HIV, AIDS, and as everyone pointed out, the list goes on and on. And there are a variety of causes for this. I know that you've talked in other sessions about the social determinants of health. I love this slide because it gives us sort of a bigger picture of all of the different areas that are impacting upon why we're seeing some of these disparities. But one of the things that I think is really important that I always try to sort of hit home in the messages that I provide around social determinants of health is that one of the reasons I think that a variety of our strategies have failed in being able to sufficiently address health disparities is that our focus always tends to be leaning towards that very last column on healthcare system. Does everyone have healthcare coverage? Can we make sure that people have insurance? Do we make sure that people have a provider and that provider is able to deliver quality care? Those are very important factors, of course. And these, I believe, should be rights, not something that we should have to earn or that socioeconomic status should play a role in whether or not someone is able to access quality care. But there are these other 5 columns here that are also playing a significant role in health outcomes and disparities, whether someone is economically stable, the kind of environment that they're living in their community and in their neighborhood, their level of education, their access to food and nutrition, and the experience of racism and discrimination. All of these factors have a significant impact on health and health outcomes. And the reality is that if we continue to see disparities in these other determinants, if we continue to see Black and Brown people being disproportionately impacted by employment, by criminal justice, by living in segregated communities where they don't have access to safe housing, safe streets, transportation, nutritious foods, if we continue to see disparities in these other areas, giving everyone health access and coverage and a doctor that's providing quality care is not going to address the issue of health disparities. We have to address equity in all of these categories if we really want to move the needle on health disparities. And I think that this is why this is important, and we have to talk about this because it's going to require much more comprehensive strategies and us as a society to recognize that we are having disparities in a variety of areas that are having a direct impact on health. And if we can't address all of them, we're going to continue to be living in this, in dealing with this situation. I want to talk a little bit about discrimination, racism, and trauma, because obviously we saw on that slide for social determinants of health that discrimination was on there. And certainly people of color are disproportionately impacted by discrimination, racism, and the trauma that results from exposure to racialized events. Racism is a mental health issue because racism causes trauma, as Natasha mentioned before, and trauma paints a direct line to mental health and mental wellness, and it has to be taken seriously. Past trauma is prominently mentioned as a reason why people are experiencing some serious mental health conditions, but the impact of racism as a trauma specifically, I think, is much less acknowledged. And that's a problem, that's a concern. Systemic racism really describes the discriminatory actions, beliefs, and unjust policies that are ingrained into our education system, our workplace, into the economy, into housing, into the criminal justice and healthcare systems. So this means that all of us are likely to experience, witness, and participate in systemic racism, intentionally or not, on a very regular basis. And of course, systemic racism arrived in the United States hundreds of years ago when the colonists took land from Native American and indigenous people, enslaved African Americans, and for many generations. But the discriminatory practices, again, intentional or not, have continued in a variety of our systems, which are continuing to cause trauma to Black and Brown communities. As Natasha correctly pointed out, we can't even talk about post-traumatic stress because there's no post, it's continuing. And it creates a cumulative impact that has a significant impact on health and wellness. So again, systemic racism creates and worsens mental health challenges for many people of color. And according to the American Sociological Association, race-related stressors have a significant impact on mental health, specifically of disadvantaged racial and ethnic minority communities. And then, of course, we have had the rise of the Black Lives Matter movement in the death and murder of George Floyd, again, one way that systemic racism is impacting mental health is through trauma, racial trauma. And this is an emotional or physical response to experiencing or witnessing racism, discrimination, or racially charged violence. Police-involved killings have had a significant impact on the mental health and wellness of Black and Brown communities. Rates of mental health challenges skyrocketed following the police killing of George Floyd. The video of his murder circulated worldwide, causing anxiety and depression among Black, Brown, Asian, Native American communities. We saw this spike being consistent, and then nearly a year later, communities had to relive this devastating death during the Derek Chauvin trial. And for many Black people in particular in the United States, this racial discrimination and police killings have led to an enhanced fear of police, anxiety when there are lights that go off behind your car, a fear of being pulled over, wondering if this could happen to you. I've been present in vehicles with my father, with my husband, with my son, who is a Black youth who is learning how to drive, and have seen that fear, that anxiety rise in them, not just when the lights come on, but anytime they see a police car, anywhere near the vehicle, I can visually see their anxieties rise. And as on more than one occasion have I had to reach out and put my arm on my husband or my son to calm their anxiety when that happens. This is real. And, regardless of, the reasons, or they haven't actually done anything wrong, we know that Black drivers are still 20% more likely to be stopped by the police than white drivers, for no discernible reason. Racial profiling still happens. And when you have exposure to trauma, whether you've been involved in it personally or not, or have just witnessed it on the media, through social media, on the news, it has an impact on you. And the effects of that we will continue to see over the next years and decades. I think it's important for us to remember that these experiences that we have all had and witnessed over the past 2 years have undoubtedly taken a toll on our mental health, on all of our mental health, in fact, not just Black and Brown communities. White communities have been having impacts from this as well, but in particular for communities of color, it's very hard to maintain positive health and wellness and a positive mental health attitude when you feel that you're living in a country where you're not safe. And the impact of that is certainly something that is important for all of us to remember and hold on to. Everyone processes racial trauma in different ways, and the effects obviously vary from person to person. Racial trauma can lead to symptoms that are very similar to post-traumatic stress disorder. There is absolutely nothing normal about racism, and it is incredibly common to experience a range of emotions when you've been exposed to a racial trauma. And this can result from a variety of different things. Major experiences of racism, such as workplace discrimination or hate crimes. We also saw a surge in mental illness and mental health concerns in the Asian American community recently, with the rise in hate crimes that community has experienced as a result of COVID-19 blaming, et cetera. And the Atlanta shooting in 2021 that killed 8 people, including 6 women of Asian descent, it has had a significant toll on that community as well. Also, the accumulation of many small occurrences, like everyday discrimination and microaggression, those common social practices that marginalize people of color, things like being mistreated or being disrespected or just being ignored when you're standing in line or waiting to get something at a restaurant, or teased with offhand racist jokes. These things accumulate and take a toll and can become very traumatizing. But then also the impact of historical trauma, which I think is something that we don't talk about enough. When we're thinking about historical trauma, we're talking about an event or set of events that happen to a group of people who share a specific identity. Each event is profoundly traumatic, and then you look at these events as a whole, and they represent an accumulation of disruption for communities. We're talking about slavery, we're talking about the Native American genocide, we're talking about the Holocaust. The wounds from historical trauma run deep and have a significant impact on one's mental health. For African Americans, we have endured being stolen from our native lands, enslaved from 1619 to 1865, systematically abused and denied education, forced breeding, widespread sexual assault, the rape of Black women and men, indentured servitude, Jim Crow laws, mass lynching, mass incarceration, and the modern day lynching of Black people played out on social media for the world to see. These are historical traumas that are continuing to have a traumatizing impact as the trauma continues in our community. But how does historical trauma impact us now? Here's my last poll question for the group. Do you think that historical traumas experienced by someone's ancestors can have an effect on that person and their current mental health or health? So again, does historical trauma experienced by one's ancestors have an impact on someone's current mental health or health? What do you think? Yes or no?
They're coming in. Got about 56%. And we'll wait just another couple seconds. All right, I'm going to go ahead and end the poll and share the results.
Well, you guys hit the nail on the head. 100% said yes, and you're absolutely right. Thank you guys for participating in that poll. But I wonder if we know why. So this is an interesting area of research that I've begun to be more excited about learning about, this area called epigenetics. And it talks about how our experiences are impacting our bodies and impact our DNA. Research that's been exploring historical trauma looks at how trauma is actually embodied or held personally and then passed down over generations to generations, such that even family members who have not directly experienced the trauma can feel the effects of that trauma generations later. Through extensive research that's actually been conducted with the children of Holocaust survivors, scientists have found evidence indicating that historical traumas actually have an impact on humans at the cellular level. And they have found that stressful environmental conditions leave an imprint or a mark on our epigenome or our cellular material that can be passed down to future generations with devastating consequences. So individual trauma then becomes collective as it affects a significant proportion of our community and becomes compounded as it's passed down from generation to generation, both socially through storytelling, through shared narratives, but also biologically from generation to generation, which is likely having a significant impact on some of the health conditions that we are seeing in our community. The impact of these traumas has an effect on a person's brain, on their body, increasing their vulnerability to a range of mental health conditions. And for Black people in particular, multiple historically traumatic events occurring over generations join this overarching legacy of assaults, creating a higher stress vulnerability that can impact a person's ability to cope effectively with current stressors as they arise. So this recognition is important. The understanding that the human body actually holds on to stress and can pass this down from generation to generation reminds us that we cannot ignore the social, historical, or cumulative experience of stress and its impact on wellness for all people. But in particular, here we're talking about African Americans and also Native and Indigenous populations in the United States. One of the things I wanted to just point out really quickly, and we're going to kind of go through the rest of these slides a little bit faster now so we can get to the question and answer period, is just to see sort of how this works. And a little bit of a flow chart to kind of give you an idea of how some of this impact takes place. When someone experiences a historical trauma in the past, we know that it has an impact biologically, but then there are consistent public and personal reminders, recurrent traumas that continue to come based upon someone's race or ethnic background, the structural inequalities that continue to be in place, even though there may be laws against some of these things happening, the barriers and the inequalities remain. Then we have personal reminders, our own perceived loss, the perceived discrimination and racism that we've individually experienced, the microaggressions that we've had throughout our daily lives, and the personal trauma, all leading to create a very strong narrative for ourselves, a salience and a significance that impacts how we view the world. And impacts how comfortable we feel in the world around us, that for many people of color creates a very low-lying, sort of consistent stress response that never goes away. And that sort of heightened alert always has a significant effect on our health and well-being, physically and mentally. And we see a range of different symptoms: intrusive thoughts for individuals who've experienced racial traumas, having an altered arousal state, engaging in avoidance behaviors or sort of a numbing, flat affect to disconnect from that trauma, a variety of mood symptoms, depression, anxiety, anger, engagement in negative coping, so substance use and abuse or other things to try to cope with those feelings, as well as physical symptoms: increased blood pressure, increased heart rate, increased stress hormones, allostatic load that we often talk about in the medical community, and an increase in chronic health conditions. And as I mentioned earlier, there is a growing body of evidence connecting these expressions of trauma to the vast array of health disparities that we see for African Americans today. And of course, we talked about all of these earlier, but in addition, severe and persistent mental illness. So I want to go back to this one really quickly, because again, our goal is health equity. Natasha talked about this, and it's important. It's something we should all care about. Health equity really is achieved when every person has the opportunity to attain his or her full health potential, and that no one is disadvantaged from achieving this potential because of their social position or socially determined circumstances or due to the color of their skin. This is something that we should all be actively fighting for. And when we think about some of the inequities that remain in mental health, I want to take us back to this before we move on. The biggest sort of disparity with regard to mental health is actually in regards to access to care and quality care and treatment. Despite the need, only 1 in 3 Black adults who need mental health care actually receive it, which is about half the rate of non-Hispanic whites. And there are similar experiences for other racial and ethnic minorities as well, who are significantly less likely to get help when they need it. African Americans are more likely to delay seeking assistance until symptoms are severe or in crisis. They're also significantly more likely to terminate treatment prematurely. Why is this? There are a variety of different factors that are impacting here, and I want to just touch on a couple of them very briefly before we move on. We know that race, ethnicity, culture, language, geographic region, and a variety of other social factors affect the perception, availability, utilization, and even the outcome of mental health services. And researchers and clinicians have looked at a number of barriers to access to treatment, specifically for mental and behavioral health, and have kind of placed them in these 4 categories: physical barriers, psychological barriers, cultural barriers, and treatment barriers. I want to talk about each of those very briefly. So physical barriers, these are the things we tend to kind of think about, and we recognize these being a huge issue. Cost and insurance, living in poverty, issues with transportation and childcare, the availability of services in one's community, the very long waits that people, especially in Florida, often have to have when they need care and are told they're going to have to wait some weeks, months even before they can get in to see someone for help. Everyone deserves equal access to quality health care and resources. And historically, Black and Indigenous people of color in America are more likely to experience a greater number of physical barriers that can place them at a greater disadvantage to being able to access mental health services. But there are also psychological barriers, and stigma and shame is something that I know Natasha has talked about, which is certainly a focus of the National Alliance on Mental Illness, and certainly something that myself as a clinician have certainly been focusing on, is wanting to reduce and eliminate the stigma and shame associated with having a mental health condition. As we talked about earlier, mental illness is a physical, biological illness. You shouldn't be any more ashamed to have depression as you should to have any other kind of physical health condition. But that's not the way that our society has worked, and particularly for communities of color, there's a greater stigma often associated with mental health conditions. One study recently found that 63% of African Americans believe that mental health conditions are a personal sign of weakness. That is a narrative that needs to change because it is deterring people from getting help. There are also negative attitudes about treatment, and some of these attitudes may stem from confidence in treatments and providers to messages that many of us may be receiving from our faith-based community, saying that, you should pray or turn to God and that you don't necessarily need to go and get professional mental health services, and other myths about mental health treatment. There's a fear and there's a mistrust that remains. And some of this is stemming from racial trauma as well, past negative experiences with the mental health treatment system. And these can be things that one person experienced themselves or things that they've witnessed or that they know about. Tuskegee was not that long ago, and it's still having an impact on people's trust of mental health services. And I certainly think it's having an impact on many communities of color's trust of the COVID-19 vaccine. Being empathetic and understanding of the reasons why communities are having a mistrust, being empathetic about that, and as opposed to judgmental, I think is a really important key for us to ensuring that our communities are safe and that they're getting the treatment that they need when they need it. Because research has shown that minority communities have a reason to mistrust. Often when minority communities go to get care, they are not receiving the same quality of care. They are often treated differently in health provider settings. I've witnessed this myself and have many clients who have told me a variety of stories. I could go on and on about the experiences of being treated differently in healthcare settings. So there's this term called healthy paranoia, that in order to protect oneself, certain communities have developed these sort of strategies for being apprehensive, asking more questions, and not just believing what a healthcare provider says, because we have a history of not being able to trust them. And that stems from a real place. And I think we have to be empathetic about that and understanding. Of course, additional cultural barriers, language barriers continue to be a significant issue, even in the state of Florida, where a very significant proportion of our population speaks Spanish. A lot of our providers are not able to provide care in other languages. A lot of our interventions are not always in line with diverse cultural norms and values. And there tends to be a lack of cultural competence among providers who are really able to understand and address the life views and the context that many communities of color live within. And then we also know there are issues with diagnoses and lack of cultural sensitivity. Many of you probably know about the one that comes to my mind first is some of the misdiagnosis in schizophrenia. And there was a long time where people believed that Black men were more likely to have schizophrenia when in fact there were just cultural differences in diagnosis, and we don't believe that to be the case. So many people were being treated for the wrong thing because of a lack of cultural sensitivity and understanding the different presentation of symptoms for different mental health conditions based upon race and ethnic background. And then treatment barriers. As I mentioned, when minorities do go to seek treatment, they're often less likely than whites to receive effective state-of-the-art treatments. We know that when African American and Latinos go into the emergency room, they're significantly less likely to be prescribed narcotics or pain medication, even for things like long bone fractures, when often things that are offered may not align with patient preferences. And if a person of color prefers to have a provider who matches their same race or ethnic background, that's very difficult to accommodate. There are not enough providers of racial and ethnic minority background to affect or to help the number of patients who actually might have that preference. And then the competence to understand and address race-based trauma. This is a big one for me. The notion that racism is a stressor that can harm or injure its targets is not recognized in psychological or psychiatric assessments and diagnostic system. In fact, the DSM uses the word discrimination once. And of the 52 external stressors noted, none of them include race-based stimuli or refer to racism. So our clinicians are not being trained to even ask about this, let alone to address and treat it in clinical settings. So there's a disconnect between what our populations need and providers who are able to give them that care. So I want to end just with the importance of making sure that we're all coping with racial trauma. This is challenging. This is affecting all of us. We have to practice self-care. We have to stay connected to our loved ones and to the social supports that we have, to seek out activism opportunities when we can, because being active and proactively fighting against injustice can certainly have a positive impact on our mental health. We have to limit our news and social media consumption. It is really easy to get wrapped up into what we're seeing on TV and in social media. We have to create boundaries and take breaks for ourselves, for our own mental health and wellness. Some people have suggested starting a gratitude journal or just writing down some of the things that you're thinking or feeling. Getting it out on paper can certainly make a positive impact. And ultimately, if you're dealing with signs or symptoms of mental health conditions that are impacting your functioning, that are long-standing, it may be time to talk to someone. And I think I'm having a glimmer of hope. Natasha talked about NAMI sharing hope. I think that right now, one of the things that have come out of these pandemics is that we're beginning to have more critical conversations about these topics than perhaps we ever have before. And again, we can't change what we don't acknowledge. So if we're able to talk about these things, I think that collectively, we're going to be able to start moving the needle and creating more solutions that are going to be effective to addressing some of these issues in our communities. I also think that the pandemic in some ways has helped to open up doors. Natasha mentioned that a lot of NAMI's programs are now being offered virtually. Virtual care has also allowed people to interact with providers that they have preference for that might not be available in the state of Florida. But for example, I'm a mental health provider and I have a therapist. I think we all should have one. And my clinician is in New York City and she's fantastic. I wouldn't have had that opportunity had this pandemic not happened. So thinking about positives and what we can do to continue to enhance the health and wellness of our communities. So I think that I've gone over, so I will stop there and I will turn it back over to Natasha to talk a little bit more about some of these issues.
Well, actually, Dr. Kyaien, you can stay, please stay, because next step is solutions. One of my favorite strategies when I'm doing anything new and how I have advised clients is start with 5%. This is a heavy work. It didn't start in 2020. It didn't start in 1950. It's been here. It's a heavy work. Again, it requires all hands on deck, but we can start where we are. What does it look like? What does change look like? How do we implement change? What would it mean if we gave 5% more effort to contributing to the change that we want to see in our community? For me, it means that I have to recognize that just because I am a Black woman, I do not stand outside of this conversation and say, hey, this is your problem, fix it. It means that I've got to contribute to the conversation. I've got to share my ideas. And I too have to be an ally, recognizing that we all come from a place of privilege. A place. It means that I need, just because I am what may be called a high functioning person with a mental illness, it means that I have an opportunity to lend my voice to those who may not be as high functioning, even though I really dislike that term. But what does 5% more effort look like? How does that look for you? And what changes can you begin to do in your own communities to ensure that we begin to dismantle these racial inequities that really are barriers to healthcare? Dr. Connor, what are some things that you're doing right now in your work to really ensure that we're breaking down and dismantling these inequities?
Yeah, that's a really great question, Natasha. And I love the way that you put that. As a clinician, one of the things that I value is recognizing that we don't move mountains overnight. And sometimes it's the steps that we can take, and we have to celebrate those small steps too, no matter how small. I think for me, one of the things that I've been trying to do is to be more vocal, to share more when I have the time to do so, to try to bring in more students, talk more about these issues, engage students so that they can be more active. Recognizing that they too have a voice and that is an important voice and an important story for them to tell. I think some of the research projects that I have focused on lately have been able to do that. As you know, Stories from the Black Community was something that I co-produced, and was really excited about that series because it really offered an opportunity for people of color from across the country to bravely share their story about their experience with mental health. And I heard from all of my students who I required to watch it that it made an impact for them. And some of them said things to me like, wow, I had stopped taking my medication because I had felt stigmatized about it. And hearing that woman's story about her experience made me realize that I might want to revisit that. And I wanted to talk to my doctor about that. You know, those things make a big impact for me. I think one of the other things that I've had to be careful about, and many of you may be experiencing some of this as well, so I think it's important to mention, is that in the fight for racial justice, often additional burden can be placed on people of color in our communities when we're already overburdened and stressed and struggling. I know for myself, I have said yes to more things than I probably should have. Joining this task force for racial diversity, and now I'm the chair for the Council on Racial Justice, and now I'm doing, you know, and that has become incredibly overwhelming for me. And my mental health has taken a toll because I'm exhausted. And so I think we also have to, while we're doing that extra 5%, take another extra 5 or 10% for yourself to ensure that you are, you know, engaging in your own personal self-care routine. And sometimes I have recognized that lately I've had to actually schedule that in to my schedule, the same way that I schedule my meetings and my classes and my presentations. I have to schedule in time for myself because ultimately I end up taking that time for myself last on the list. And I'm not going to be good for anybody else if I'm not okay. And we, as members of the Black community, cannot do all of this work ourselves. We didn't create these issues ourselves, and it's not on us to solve all of them ourselves. And I think it's really great, to your point, Natasha, that we all have a role in this. We all have a stake in this fight, and all of our voices are incredibly important. And in some circumstances, the voices of non-Hispanic whites in this anti-racism effort can even go further than some of our voices. And so those allies are incredibly important. So please use your voice, share what you know, and whatever sort of weapon you have to engage in this fight, do that, right? I'm an educator, so I educate, that's my weapon. But a lot of us have different weapons that we can engage in, whether that's in your spiritual community, or whether that's working with kids and youth and getting them engaged, or, you know, bringing programs into the communities, or whatever it is your weapon to bring to bear, bring it. And we can work together to create solutions.
Absolutely.
I want to thank you both. This is an incredible conversation, and bring your attention to some of the wonderful questions that have come in. So I'm going to start with actually asking both of you this question. But how did you become comfortable with sharing your diagnoses and your stories with the world?
Great question. When the pain of remaining silent hurt more than any stigma or shame I could imagine. When I realized that I was stifling my skills, talents, abilities, voice, because I was afraid of potential stigma and potential backlash. And what helped me through it, I worked with a coach who said, Natasha, okay, you were a publicist. If you had a client that, you know, had a mental illness and, you know, TMZ shoved a microphone in their face, what statement would you give to the press? And so I wrote the statement that I would give, and that helped me to release a lot of the pain and the shame and even the self-stigma. And then we spoke about This Is My Brave before, but September 2019, I took the stage in Orlando for This Is My Brave, and I shared my story publicly for the first time. Incredibly cathartic. And now I've got to keep sharing, and I will keep sharing, because if I'm comfortable telling you, hey, I'm going to leave early to get my teeth cleaned, I should be just as comfortable telling you, hey, I need to refill my prescription, I need to go see my therapist. So it was a deliberate choice that I made, that I'm gonna, if it's taking one for the team, whatever it is, I don't care, because I know that for me, this is life or death. And for so many others, it is as well. Mm-hmm.
I don't really have much to add to that. I don't want to follow up Natasha's statement on that at all. But I will say that I think for me, it's recognizing that, especially as an educator and working with students, that when people see you as a role model, even small bits of a story that you can share, when you see that it's having an impact, potentially on saving someone else's life, that is reason enough. And so over the course of my years as an educator, I've gotten a lot more comfortable being very transparent with the people around me, because I have found that it gives them permission to feel comfortable doing the same. And if I'm able to be the spark that allows them to feel comfortable having those moments, then, for me, that means everything.
Thank you. Do you think that it may help to change the stigma for mental illness if the word illness could be replaced? And so I would talk about maybe, we refer to mental illness, mental health, behavioral health, I think, in so many different ways. I suppose why use one versus the other, and what are the differences perhaps?
Great question. 1 in 5 people live with a mental illness. That's something that's been diagnosed by a mental health provider. 5 in 5 people have a mind. And so if you have a mind, mental health should be a concern for you. We're not talking about diagnoses. We're talking about things just like life stress, feeling overwhelmed, grief. Those aren't mental illnesses. Those are mental health challenges. And changing the word illness, I think that would be semantics. If that's the case, we need to change cancer, lupus, hypertension. We need to ensure that none of those are ever called illnesses. The terminology isn't the challenge, it's the stigma that surrounds it. And that stigma is only going to be eradicated with education and with knowledge. Years ago, back in 1991, HIV and AIDS, oh my God, we weren't touching anything. We were so afraid of it. And now it's like people are living healthy and fulfilling lives with it. The same is true for mental illness.
I agree with that 100%. I guess the only thing I would add is that I think that there was actually a intentional idea behind calling mental health conditions mental illness, in order to help really make the connection that it is a illness, a chronic illness, just like any other physical illness, and not wanting to have it be separated or treated differently, which is really the fight for parity too, right? The idea is that mental health conditions, mental illness, whatever you call it, it's an illness just like any other physical illness, and should be treated the same and should be offered the same sort of benefits through our insurance programs and be seen the same in society. So I don't know. I agree with Natasha. I don't know if changing the word is really going to make a big difference ultimately. It's really about recognizing that stigma that's around that phenomenon, whatever we're going to call it, and trying our best to mitigate it. And research tells us that the best ways to mitigate stigma are through education, advocacy, and contact. Having accurate information, advocating for rights, and then having contact with other people who have shared their story, and who, once you have contact with someone who has experienced a mental health condition, stigma does tend to reduce. And that's part of the benefit of This Is My Brave and other platforms for storytelling, because it really does help make a difference. And those have been the 3 ways that have been identified by research that have had the most success in reducing stigma, contact being the number 1 strategy.
I want to, we've got a kind of 2 questions in the chat that I think they're both kind of related. What can those of us not in the Black community do, and will you let us? And then I suppose this is more of a comment along the same lines. I begin to feel guilty about being white. It seems that the news is trying to make us all look bad. Can you discuss that a little bit?
I'll take this one to start, and I'm going to be very transparent because it's something that has broken my heart this year, and it's avoidable. I think for people who are not in Black communities, And even as a Black woman, I'm going to include Black men in this. I need you to use your privilege when it matters. I need Black men to use their male privilege. I need white women to use their white privilege for me when it matters. You know, Black women have been called strong, Black women for years. Sometimes I don't want to be strong, especially when you can step in. So that term ally, no one gets to test out of being an ally. We are all allies. And for me, allyship means that you are using your privilege when it matters, which means in the moment, not via text or an email or a phone call later, in the meeting, in the session, in the grocery store, right in the moment. That's when I really need to see and feel your allyship. That's where we can begin.
I love that, Natasha, and I love what somebody else said in the chat. She said, you know, stop telling me to be resilient and show me support. I love that. I know we're getting short on time, but I wanted to quickly say, as a clinician for non-Black clinicians, providers, et cetera, one of the things that I would like to see all of us do is to not necessarily move towards being culturally competent. That's a whole other conversation for another day, that I don't really agree with that term, because you can never be competent in anyone else's culture or background. But taking a culturally humble stance, don't ignore someone's race and ethnicity by saying, I don't see color. You're really doing a huge disservice to a person who their racial identity is a huge part of who they are, and they are completely aware of it every time they walk out the door. And your inability to see it or to say that is actually doing more harm than good. I think it's important that we recognize and are open to have those conversations, especially in clinical settings. Don't shy away from that conversation. Put it on the table. Recognize that I may come from a different background than you. You've had different experiences than I have had. I'm open to hearing about some of the traumatizing things that you have experienced due to your race. I may not fully understand, but I want you to know that I care and I would like to understand. And I want you to be able to open up that line of conversation with me. Just doing those things and coming from a genuine place, I think, could make a big difference in moving towards cultural humility and helping people of color to feel more comfortable in clinical encounters when they don't have the choice to see a clinician that looks like them. And that's something we can not just do in clinical settings, but things we can do in our professional settings, in our communities. Ask questions, open up the dialogue. Don't try to pretend that these things aren't happening around us, because we know that they are. It's okay to talk about them, and you don't have to feel guilty for being white at all. Please don't do that, but do recognize that you may be experiencing privilege because of your whiteness. And if you use that to better this fight, then you're helping us. And that's the best thing that we could ask for.
I've got tears behind my eyes. You guys are incredible. And I hate to be the one that has to do this and bring this to a close. But I think that we can agree this is really not a close. This is a beginning. And that's what these webinars have been all about. And so I want to start by just saying thank you, Natasha and Dr. Connor, for your incredible knowledge, your strength, your continued dedication to all of these issues, because there's many that are packed in here. And I think one of you said it takes time, and it does. But I think the important thing is to take that time to do it. So thank you so much. And I also want to, again, thank BayCare for their support in this important series of webinars and allowing for these discussions. Couple of things I want to close up with. I know that there were a couple of questions we did not get to answer today. I will make sure that the two of you receive them and can address them directly. So don't worry, you will get those questions. I also want to share with you one of the questions was around ACEs training, and not so shameless plug, but a great open opportunity, because we, the Health Council with, together with Manatee County Health Department is hosting a two opportunities for training. One is next Friday and one is the Friday after. And I am trying to load the flyer here into the chat. It will also be sent out so that you can sign up for that training. This is the 5th of 6 Eyes on Equity webinars. So I want to remind you, if you have not registered already, our last webinar will take place on September 15th. It is a Wednesday. So almost all of the webinars have been on Friday. So make sure you've got it on your calendar correctly. This is where we're going to really bring it home and not just discuss, but begin to discuss what actions we can begin to take. We do so much learning, and we always need to learn. There's always something to learn, but we also have to take what we learn and act with it. So I'm excited to share with you that the next and final session will be titled The Next Steps for a Cross-Sector Approach to Health Equity, Leading to System-Wide Progress. I have also loaded the flyer in and will be sending a recording of this webinar to you as soon as it is ready, along with presentations and a list of resources. Please don't forget to take the survey that will pop up after we close the webinar, and you will also get it in that email as well. If you have any questions, you all have my email address because I emailed you to make sure you'd be here today. And I, again, appreciate all your time, your great participation through both of the chat and the poll, and look forward to seeing you in September. Have a wonderful day. Thank you.